Hi guys, this is Giulia and welcome to the lecture about SIADH. SIADH is defined as the syndrome of inappropriate antidiuretic hormone secretion. And it happens when there are high levels of ADH which induce free water retention and cause euvolemic hyponatremia. Why is it important? Acute symptomatic hyponatremia is one of the medical and oncological emergencies because it can lead to fatal cerebral edema. We define acute when the hyponatremia develops in less than 48 hours, which means that the brain will not have enough time to adapt to the change in osmolality, and this will bring a high risk of cerebral edema. On the other side, chronic hyponatremia is not an emergency. It means that the hyponatremia has been developing in days, weeks, or in general more than 48 hours, and usually the brain will have the time to adapt, so patients might be asymptomatic. Let's talk about the etiology of SIADH. Generally, the most frequent cause is malignancy, and this is because a lot of tumors can ectopically produce ADH. The most frequent one will be small cell lung cancer. In fact, up to 45% of patients with small cell lung cancer can have SIADH. And we also have to remember that cancer patients can have other mechanisms of production of ADH because they can have frequent nausea, frequent pain. They can be taking medications that would induce SIADH. A lot of drugs, in fact, can cause SIADH because they can increase the release of the hormone. Chemotherapy, but also SSRIs, ACE inhibitors, antipsychotics, so medications that are widely used in our population. Then we have CNS disorders, so a lot of diseases like brain tumors or bleeds or infection can increase the release of ADH, and lung diseases. There are other less common causes of SIADH that, of course, we also have to consider in specific cases. What is the clinical presentation of hyponatremia? It really depends on the rate of the development of hyponatremia, so if it's acute versus chronic. Symptoms are caused by the dilution and loss of sodium, so are similar to dehydration. And as the concentration of sodium becomes lower, the brain begins to swell, so we will start to have signs of cerebral edema and irritation. We can have mild symptoms and severe symptoms, which will depend on the rate and also on the level of sodium. Mild symptoms can be nausea, vomit, headaches, lethargy, tremors, but also gait instability, so patients that start to fall multiple times. And severe symptoms, where we definitely have cerebral edema, can be delirium, seizures, but also respiratory depression. Let's review the diagnosis of SIADH, which requires specific diagnostic criteria. First of all, very important, the patient has to be euvolemic, so we do not have orthostatic changes, the vital signs are stable, there's no edema, so no signs of hypervolemia or hypovolemia. Second step, the serum. So we have, of course, hyponatremia, so the amount of sodium in the blood is very low, with the osmolality that is also low. And then the urine. On the other side, the urine will be normally concentrated, so with an osmolarity of more than 100, so there's going to be a lot of sodium in the urine on the other side, and the urine sodium is actually high, so usually more than 40. Some other diagnostic criteria that we can find are hypouricemia, less than 4, and a urea of less than 10. We can then stratify depending on the severity of a hyponatremia. We will have mild if the sodium is between 130 and 134, moderate if it's 120 to 129, and severe when it's less than 120. What do we do when we have a patient with hyponatremia? Workup. So if we're suspecting SIADH, we will have to kind of rule out all the causes. We said that there's cancer, pulmonary disease, CNS, drugs, so that's basically how we are thinking about the patient. First of all, we have to make sure that the hyponatremia is true, so we will repeat the BMP, and then we have to correct for other possible causes of hyperglycemia that might mimic hyponatremia. We have to see if the patient has hypertriglyceridemia, if the proteins are elevated. We recheck the BMP, as we just said, and then at this point we have to see what's the osmolarity in the blood, so we send the serum osm in the urine, and then we want to know the electrolytes. We will send the urine sodium and the urine potassium to see what's the concentration of the urine. We have to rule out other causes that can mimic SIADH, because both hypothyroidism and adrenal insufficiency can actually have a euvolemic hyponatremia picture. So we will send a TSH and the cortisol. And then we have to make sure that the patient is not taking medications that can also cause natriuresis, specifically diuretic use. And then, of course, we will go over all the medications, because if the patient is taking chemotherapy, SSRIs, then we will have a better idea of the cause of the SIADH. And then these are more specific tests. So once we have done all the screening and we want to try to find out the reason that the patient has SIADH, we might look for lung disease, we might look for neurological conditions. So this is just a general indication, but it's not really specific to the case. What is the management? So it's kind of complicated, right? Because it depends on the rate of the hyponatremia, on the severity, on the symptoms. Rule number 1, it's extremely important to avoid overcorrection, because that can cause osmotic demyelination syndrome, which we always want to avoid. But the best rule to remember is also that the underlying cause is always the first thing that we need to treat. So, for example, if we have an offending drug, if we have a meningitis, so we have to treat the specific trigger. Then we have to assess for symptoms. So as we said, every patient might have severe, mild symptoms, or might be asymptomatic, and that will change our management. And then we have to consider consulting nephrology if the patient has severe hyponatremia or if he's symptomatic. Once we start with the treatment, which will depend on the type of and severity of hyponatremia, we will also monitor with the BMP every 4 or every 6 hours. Sometimes nephrology might ask for every 2 hours, but we know that that's kind of impossible. Okay, let's stratify our patients and our scenarios. Case number 1 might be acute asymptomatic hyponatremia, which is pretty rare to encounter, because if the patient is asymptomatic, we are going to assume that the hyponatremia is chronic. One scenario might be if, for example, we have a patient that was in the hospital a couple of days ago and we have normal blood draws. In these cases, if the patient is asymptomatic, as we were saying, then we can probably just do fluid restriction and maybe give some salt tabs. If we have severe hyponatremia though, so we have very, very low sodium, then we should consider to do hypertonic saline. Second scenario, the most dread one, acute symptomatic hyponatremia. So this is the medical emergency, because we have to quickly increase the level of the sodium to prevent neurological injury, of course. The target is usually 1 to 2 millimoles per hour, and in general we cannot go over 8 to 10 in the first 24 hours. In this scenario, the treatment will depend on the severity of symptoms. If we have a patient with very severe symptoms, so seizures, coma, signs of cerebral edema and irritation, we want to avoid cerebral herniation. So we're going to jump to the hypertonic saline, and we usually give a bolus, because our goal is to rise the sodium quickly, because we want to avoid cerebral herniation. Hypertonic saline is used because it has a osmolarity that is higher than the patient's urine, so it will help basically waste water. Sometimes nephrology will also give dextrose or desmopressin, because when we give hypertonic saline, we might have overcorrection, so we have to balance the effect of the two things. On the other side, if the patient has mild to moderate symptoms, so less likely is going to go into cerebral herniation, we can be less aggressive. We can do fluid restrictions and salt tabs. Or if we are more concerned for the patient, we can also use the hypertonic saline, but instead of giving a bolus, we can do a continuous infusion. Let's change pace and let's go to the chronic hyponatremia. In this case, the goal of correction is much different than the acute hyponatremia. We want to go very, very slowly in this case, because we want to avoid the opposite of cerebral edema, which is the central point in malinolysis. We are going to try to increase the sodium with a goal of 4 to 6, so very, very slowly in 24 hours. And this is the reason why fluid restriction is the first line. This will allow us to have a very slow recovery and can be associated with a salt-liberal diet or supplemented salt tabs if we need. Less frequently used medications can be demeclocycline, which is an antibiotic that can block the AVP effect and cause diabetes insipidus. but it's a medication with many side effects. It can cause nausea, it can cause anorexia, it's actually an antibiotic. It requires weeks of treatment to improve the sodium, so it's usually avoided. Or the Vaptans, that are an antagonist of the V2 receptors and can also increase the free water clearance. They also have many side effects and they're also expensive, so they are not always used in the hyponatremia treatment. Finally, this is only a table that summarizes what we discussed about and the different steps that we undertake when we have a patient with euvolemic hyponatremia. And as we said, we will confirm the SIADH with the labs, and we will see if the patient is asymptomatic or if he has a very mild hyponatremia, and then we will do fluid restriction, which is usually enough. If the patient is symptomatic or has severe hyponatremia, and they usually go together, we will consider, of course, the help of specialists, and then we will have to see if the situation is acute or chronic. If it's a chronic situation, most of the times fluid restriction might be enough. If it's acute, then we will probably have to jump to hypertonic saline. Good job, guys. We are at the end of our lecture today. The take-home points will be to remember the diagnostic criteria of SIADH, stratify the patients depending on the symptoms and on the severity and rate of hyponatremia, and then remember always that acute hyponatremia requires a faster correction than chronic hyponatremia. Thank you for staying with me, and this is a handout that you can print and it summarizes what we talked about today. Thank you guys, have a great day.